case from the last meeting. So I would like to invite Dr. Srivastava sir to say a few words, and then we'll right away jump into the case presentation. Srivastava sir, please.
Yeah, a very good evening to all of you. On behalf of Bombay Spine Society, I welcome all the members. Dr. Sandeep, Dr. Amit, and Dr. Uday. They have coordinated very nicely, and we have series of cases. Today we are going to have a session on spinal tumor, and Dr. Boriani is going to join us to deliver his talk on metastatic tumor management. And Dr. Boriani is going to. There is some echo. Anyway. So I will hand over the proceeding to Dr. Amit and Dr. Sandeep. So you please start the thing in time, so it will be better. We can discuss it in great length. Okay, Dr. Amit, hand over to you.
Thank you, sir. Thank you very much. Agnivesh, are you ready? So we'll start with the first case by Dr. Agnivesh Tikku, and Agnivesh, you want to present the case from your end, or do you want me to run the PPT from here and then you just want to speak about it?
No, I can share the screen. So
Good. Go ahead then, please. Yeah.
So is the screen visible?
Yes. Go ahead.
Okay. Good evening, everyone. So today I will be discussing one case of a 67-year-old male who presented with neck pain more at night for last 2 months, and also complaining of some gait imbalance and grip weakness. Lower limb there was hyperreflexia, plantars were extensor, and the power was grade 3 to 4 in the lower limbs. He had severe gait imbalance while walking, and this is the MRI of the patient. So anyone would like to comment, or should I move ahead?
I think go ahead, Agnivesh, go ahead for the time being.
All right. So the blood workup was done, which showed that it's a raised ESR. Serum kappa lambda chin were normal. The LFT, RFT urine examination was okay. So at this point of time, I would like Dr. Amit to begin with you. Let me catch hold of you only. That looking at this MRI, would you think of starting AKT or no? What is the opinion of the seniors in the group that there are many people who would start AKT looking at this MRI, thinking it's TB and all?
See, number one, it's not a typical Cox presentation. It's a more of the body involvement than the disc. And I mean, we have these gut feelings, like just by looking, though TB can mimic in any way, but TB will not be definitely first diagnosis in this case. And even if somebody claims that it is TB only, I would still like to go ahead and have some kind of sample to ensure that which kind of whether it's an MDR or sensitive TB, and before that starting any kind of treatment will be may not be the right kind of thing to do in the current era.
All right.
Yeah.
So Agnivesh, can I add something?
Sure, please go ahead.
Yeah. So also in the MRI, if you see, the disc is not involved, and the body which is there, the T1 body is showing a ballooning and it's showing permeative lesion. So it's more tilting towards the fact it's like a non-TB, maybe primary metastatic or some other pathological involvement rather than a discovertebral involvement.
Another thing
Right.
I would like to point out, Dr. Agnivesh,
Yes,
it is better to follow the sequence which we follow, like plain X-ray first, because sometimes metastasis is picked up by your plain X-ray AP view. You will find the particular area is involved. Okay. Now here in MRI also, if you see the proximal body, one body is collapsed, significantly. The proximal body, the posterior half is gone. Okay. So atypical eating away of the body, and that creates doubt in one's mind. Okay, this doesn't appear to be something else, rather than I will try to keep that in mind, and then further investigation is required. Okay. Yeah,
I
go ahead,
agree,
please.
sir.
Sorry, and
One question.
if I may intervene, this MRI looks nothing at all like TB. I mean, forget the fact that we are in a metastatic session. Clearly, this is an iso-intense lesion. There is no abscess, there is no soft tissue. And you can see, more importantly, the pedicles are involved. So when the pedicle and the posterior elements are involved, the chances of it being TB are less. A disclaimer here is that TB is a great mimic, and TB can mimic anything. But based on this MRI, this is not a classic TB. If the same thing, if there were abscesses around, a real abscess, then I would say, okay, it's an infection. It may still not be TB, but it's an infection. But this comes definitely in favor of a neoplasm. It's iso-intense and the pedicles are involved. So that's another thing. The other thing is, based on clinical grounds as well, this is not a case which is going to go for biopsy. It's going to go for treatment, which we'll come to in a minute, I'm sure.
So can I add something over here? So if you, like S K sir said, that in this particular case, the MRI sometimes can show us an exaggerated picture. And so if you actually look at the X-rays, although this area might not be visible, the X-rays will show that the cortical shell of the body might be intact. And also the CT scan, if you do, which is the earliest thing that we do in cases like this, because this particular area might not be visible too well on the X-ray picture.
Yes, that is what I was trying to ask the next question, that this is a cervico-dorsal junction. AP we may still be able to see, but lateral we may not be even able to visualize this area in the X-ray. Anyways, since he had neurology, so he had already come with an MRI only in his hand. So then would somebody think of doing some more investigations before going in directly for treatment, or directly a decompression and a biopsy, open biopsy is needed?
What does the spine screening show?
So spine screening lower down did not show any other lesion. This was a solitary lesion.
Okay. And you ruled out all of the primaries in here and there?
So yes, we did a PET CT after that. It showed the disease is in multiple areas, but around the same area only. There was some segment in liver which was seen, which said that it could represent the site of possible primary malignancy, but they were not very sure about it. And the serum markers, anyways, they were not very raised or anything to point out. So typically, they were not able to. The oncologists were not able to point out to any particular pathology in this case.
Kedar, would you like to add something to this? Kedar, you're muted.
Yes. So I think the bottom line, which I would think in these cases, is if we don't have neurodeficit or very mild neurodeficit, we should investigate thoroughly and try to get the diagnosis. Because in some cases where the diagnosis turns out to be lymphoma or myeloma, the role for surgery is quite limited. And also for tuberculosis, the role for surgery is limited if there is no neurodeficit and the spine is stable. So if there is neurodeficit, you are in a rush to decompress before the diagnosis. But if you have the luxury of normal neurology, I would investigate thoroughly, get to the diagnosis, then only decide treatment plan.
So he has great core power.
So what would be your sequence of actually asking for the investigations in this particular case, where a patient comes with an MRI picture, it is not classically tuberculosis, so how would you go about it?
So I would like to get the blood workup done, and I definitely ask for myeloma workup, and also simultaneously I would ask for PET CT. The other thing I would do at the same time is get the oncologist involved, because this looks like a malignancy to me more than a metastasis. So I usually tend to get them early involved. So, so PET CT, blood workup, and oncology opinion.
So Agnesh, what did you do?
So since the patient did not have a major deficit, so this is the CT scan of the patient showing the involvement of the bone over there. And since he did not have a major deficit, we did a CT guided biopsy and from the soft tissue, and we got the report as this, which showed that it's a metastatic deposit of a carcinoma. Again, they could not type it which grade type of carcinoma, because it was high grade undifferentiated type of a, you can see a purely differentiated carcinoma. So it was a high grade carcinoma, and considering the primary that the PET CT was pointing something towards liver, the oncologist said that this is a very high grade type of lesion, which is very aggressive because it is metastasized to the bone, and the life expectancy is not going to be very high. He was pointing it somewhere between, say, 9 months to 1.5, 2 years. That was the maximum what he said. So with all of this information, what would be our plan of surgery now?
No, so Agnivesh, can you just go back to the slide that you showed? No, the report of histopathology.
Yes, sir.
Yeah. So let me ask Dr. Srivastava sir, as to when you get a report like this, what do you actually, how do you actually judge what could be the prognosis? Because this is a very non-specific sort of a diagnosis that we have in hand right now. And how much should we actually trust when somebody says that the life expectancy, that is what they can actually predict on this report? Would you go in for this?
No. Actually, it is very difficult to comment. Okay, life expectancy is this much only, and moreover, it is not clearly mentioned deposits of carcinoma. Now, if you have adenocarcinoma, you think something else. Now, this carcinoma is a very broader term. He has not even mentioned, adenocarcinoma. But since they are talking in terms of liver, it will be that only. Other side of this is the actually lung parenchyma, and so these tissues like thyroid and all, these are the sources of this metastasis if the report is like this. But it is very difficult to mention about the longevity, or how much the patient is going to survive. So response may be different, though with the PET you come to know that so many areas are involved, and then you start thinking more so if the vital structures are nearby. So it is difficult to prognosticate, but definitely you say that poor because multiple sites are involved. Now, even the opinion of the physician is important. Onco-physician is important because they will be telling how sensitive this tumor would be with the current line of management. I think they will be in the driver's seat how to manage this. We come in play for neurology. So at the most, what you are going to do, you are going to decompress the neural structure, and you have to reconstruct the column. So that is the only thing is in our management part. Okay.
Right.
Sir, can I add one thing?
Yeah.
Sir, in this report, it's partially, it's still pending, because with immunotherapy and targeted therapy now, if we do the complete immunohistochemistry, and if we come and if one of them comes positive for a targeted therapy, then the life expectancy can suddenly increase from an average of 9 months to a year to 3.5, 4 years. So probably if we are not rushed into surgery, and if we have time, we could wait for that complete IHC panel to come back.
No, chemotherapy actually it has changed. I still remember a case we did. So that was a case of metastasis in cervical spine. Patient came with the deficit. We operated. In fact, when the people from Tata, they came to know, they started scolding the patient. Why did you get operated? It was not required. All those
Correct.
things. But that patient survived for surprisingly almost 5.5 years.
Correct, sir.
Okay?
So they strongly recommend that you wait for the IHC results to come before you finalize the life expectancy of the patient.
Yeah.
Right. So here, whatever I'm quoting is from the oncology department.
Yes.
They studied the patient with respect to his liver status also, because he had a cirrhotic liver. He was alcoholic. So he, all of that, whatever I'm saying were the words of the oncology department. Means I am nobody to calculate the life expectancy.
So what was done, Agnivesh?
So that's what, since it's, let's believe we are believing it to be a carcinoma from a hepatic source. So at this point of time, what would be the ideal plan? Sort of embolize this tumor going from the front or going from the back, or do a combined surgery? What is the opinion of the seniors with respect to this tumor?
So I'd like to say something. It's also very, very important for us to know what is the radio sensitivity of this tumor. It's very
No,
important. Secondly,
yes,
we need to see the axial sections. We need to see the axial sections, and yeah.
sir, of the CT or MRI?
MRI.
All right. Sir, I have some index sections.
Yeah, it was there.
Starting.
Yeah, this is the third.
Yeah. So I would say that this patient, if you ask me the definitive management for this patient with, liver cell carcinoma and life expectancy of around 9 months, though we are debating that, I would say that we don't need to do anything aggressive in this patient. We just need to stabilize this patient and send this patient for radiation. He doesn't have a gross neurological deficit. He has grade 4. So our surgery is not for neuro recovery, it's for neuroprotection. And his problem there is a mechanical instability which is likely to precipitate into a further sort of neurological deficit. So we just stabilize him and send him for radiation and for the other treatment. So nothing, there's nothing huge which we need to do. I mean, we can embolize if we want to, but we don't need to, because if you're doing it posteriorly, a long posterior, and do a laminectomy, you're not really touching the tumor.
So and
as such, liver tumors are not very vascular. If you want to do an embolization, you can do it, but it just eats away that 1.5 lakhs extra from the patient. That's all.
And the second thing, Agnivesh, over here is we are assuming that the grade 4 Pawar is because of the tumor itself. If you look at the MRI, there is significant compression posteriorly at the higher levels also. So we are really not sure whether that grade 4 Pawar, where you categorize into a myelopathy part of sort of a thing, is actually the anterior compression which is the cause of it.
But the level was matching. Basically, grip weakness and everything below that, it was matching with the C8 T1 level, and so that is why clinically we were believing that something, whatever is there, is because of the same lesion only.
Okay.
So, Agnivesh, this case is still pre-op, or you had done the surgery?
No, I have done the surgery. So what happened in the next 48 hours is that the patient started deteriorating. So we had to take him up for surgery. So his power deteriorated to grade 3. He became non-walker. So we had to take him immediately. So what I did was a posterior laminectomy and stabilization with a tapered sort of a rod, upper side lateral mass screws and below pedicle screws. And he improved after the surgery. He came for follow-up actually till 1.5 years. And after that, he has not reported. So honestly, I don't know whether he's right now he survived or not. But at least 1.5 years he was walking and moving around till that.
So what did the intraoperative sample? What was the intraoperative? You must have some intraoperative tissue. So what was the report?
Yes. So it came as a metastatic deposit of hepatocellular carcinoma. So this was it. But one thing that this bled like anything, even though we did the posterior surgery, we did just laminectomy from there. We tried to sort of just separate the cord from the tumor, it was almost coming onto the lateral side, and it bled like anything. It took us 1 hour to do the fixation and laminectomy, but around 45 minutes to just control that bleeding. So eventually we controlled the bleeding with the mixture of fibrillar Surgicel and the TC. So we mixed both of those and just plugged them and kept on doing this again and again till the whole bleeding stopped. So this was again a learning point that we thought it would not bleed, but it actually bled very heavily on the table. So that was another learning point for us in this case.
Can I put one comment here? So now on these cases where we have a doubt of bleeding, or we don't want to expose the tumor site first. So I think the fixation anchor we should take first. Okay. So your fixation is almost over. And then if we touch that area, and then one side rod, and then so that is the way if one wants to have that problem sorted out. Though still it will bleed. Sir. Yeah, still it will bleed.
I agree, sir. So we did the stabilization. We put the rods. We did laminectomy after putting the rods. Okay. It was just we were separating it from the posterolateral and the lateral part. It bled like anything.
Did you radiate it afterwards?
No. The oncologist said that this is not radiosensitive. That is what he said. So he had given some chemo or something for this, but he said it is not radiosensitive, so it's not going to work. Right.
Thank you, Agnivesh. Anybody has any other question for Dr. Tikku?
Just one question. The fantastic case, 1.5 year for a metastatic carcinoma of liver is very great result. and I'm not aware of any targeted specific treatment for liver treatment, as Priyank was mentioning. It's mostly for lungs and some for probably kidneys, as far as I know.
Thyroid and all are there.
So yeah, I think this is what the maximum we could do.
Okay, Agnivesh, thanks a lot.
Thank
We'll
you.
move on to our next case to be presented by Dr. Kedar. Kedar, you want me to run your PPTs?
Yes, please.
Okay, 1 second. Go ahead, Kedar.
Okay. Good evening, everybody. I'm going to present a case of a solitary metastasis from renal cell and how I managed the case. So basically, there are a lot of strategies for managing tumors of the spine, metastasis in particular. And the fundamental is if the metastases are numerous, the disease is spread everywhere, and the prognosis is not very good, then you don't do anything aggressive because the disease is widespread anyway. However, numerous cores have been devised where you can try to remove them completely. In case the prognosis is good, there is only one location, and the chemo available for that tumor is quite good. So numerous cores have been devised. This is just what is relevant in this case. Next slide. Amit. So there was a patient with a known renal cell carcinoma who presented with metastasis in the spine, a 59-year-old. He had the diagnosis was 2 years before this presentation, and a radical nephrectomy was done. And he presented with back pain, mild difficulty in walking. And he came to us with MRI and PET CT already done, which showed an isolated metastasis in his spine. So this is the stir sagittal sequences where you can see that the metastasis involves only the posterior elements. The anterior elements were not involved, and it involved the posterior elements of L1 and L2 vertebrae. These are coronal cuts which show the extent, and the lesion also invaded into the paraspinal muscles, and also it also touched the dorsolateral fascia. These are the axials, and that is the CT scan which clearly shows the amount of bony destruction caused by the lesion. Next slide. Further scanning which showed the destruction. Then we also got some flexion extension views, and this is the PET CT. Flexion extension, there was no instability. And in the PET CT, next slide, workup we did where we were sure that this was the only lesion presenting over here. So just go to the previous one. So basically, Amit, shall I proceed, or shall we take an opinion as to what people would do in this kind of case? Reasonably normal neurology. 2 years ago, renal cell nephrectomy was done and presents with back pain and shows an isolated lesion.
So there is no deficit, Kedar, right?
No deficit.
Okay.
Patient is a walker. Very mild.
So Kedar, can you we'll just hold on one sec. We'll have an opinion of the house over here. So can I get in Mihir over here? Mihir, are you around?
I'm around.
Yeah. So Mihir, can you just tell us how you would like to proceed in this particular case? Any classification you follow for staging this tumor, and what are your thought process behind this?
No, actually, I think there was an interesting conversation on the previous case also. I think in metastatic tumors, I just consider to be a part of the team unless there is overwhelming evidence that I need to be the first member to take a decision. Now, in this particular situation where there is a solitary met involving only the posterior lesion, but it into the pedicles, and it is involving the posterior half of the body, as you can see on the PET. So really doing a debridement procedure without any neurodeficit is as equivalent to, sort of not doing anything. So there is an instability. So what you need to do is plan a resection of the tumor, stabilize the spine, and subject the tumor to radiation and chemotherapy. I think doing a vertebrectomy in this particular case would be an aggressive procedure, as the tumor is already out of the compartments. It's not going to serve any purpose.
Can we see the MRI axials again? Yes. So Mihir, the body was not involved. The pedicles were involved in this case.
So
the body was spared.
So theoretically, when the pedicles are involved, it is an invasion into the middle column. So when we talk of the middle column, that's why there is an instability and a sort of tumor presenting with a lytic vertebra. So both the pedicles are destroyed and the tumor has already invaded into the posterior third of the body. So that is what we assume, because the PET scan is already showing an uptake into the posterior body wall. Have you seen the PET scan? All of you, the PET scan is already showing that there is an invasion beyond the margins of the pedicle clearly into the posterior third of the body. Though the MRI...
Yes. There was an epidural mass over there.
So Kedar, that is what I was going to ask, that just because the patient doesn't have any neurological deficit doesn't mean that there is no invasion of the dura.
No. There was an epidural mass, only that it was not large enough to compress the cord and cause major neurodeficit.
So the thing is that also there is, the tumor has expanded outside the compartment, so the pressure automatically gets diffused. The canal is no longer a closed space, so the cord gets a little breathing space because the tumor is growing outward. The bone is getting destroyed, and that's why the neurological deficit is getting delayed. However, in this case, really it is the tumor is already spread extra to more than one level, and it is already involving the body, the posterior third of the body at one level. So really doing any kind of R-block resection in such a disease is theoretically possible. Practically it is not possible, and one should listen to the advice of our onco colleagues as to what is the behavior of this tumor in the long term, because RCCs are very aggressive and the average life expectancy is about 14 months.
Yeah, that was the case before, but nowadays RCCs with the newer modalities, targeted monoclonal antibodies, we have seen, I mean, the oncologists have told me that nowadays they live much longer than what was the case in the past.
So, Kedar, just in spine, we tend to kind of, wait till the neurology gets involved. But I think here there are clear-cut evidence of instability. The two columns of the spine are almost gone. We can see the defect very well on the CT scan. So, are you not worried about the mechanical part of the spine here in terms of making a decision?
But no, in the flexion extension views, there is no instability and the patient is walking. So
I think here, you see, it's almost like having a pars fracture. You see that the posterior elements are totally gone.
Yeah, but there is no translation anteriorly of the L1 over L2.
So Kedar, sorry, Mir, go on.
So anterior elements in terms of the entire structure of the vertebral body and the disc is still intact. So one gets a feeling that there's no there is no vertebral instability at this point, which is very, very starkly staring at you. But this is an ongoing process. Correct. That means it's going to involve more and more of the body slowly. And really, this you have to start, at least assume that it's at a pre-instability stage, and you have to arrest it here. The only issue is how much of the tumor are you going to remove surgically in an attempt in your mind to give a cure. You understand what I'm saying? So are you going to go in looking at the instability part of it, or are you going to go in thinking that I'm going to remove the whole lesion?
So basically, what we put these two options to the patient. that there is, you can just remove intralesional and accept that some of it is left behind, but we will stabilize it and the rest of it will be chemo, etc. Or the other option is to go a little bit more aggressive. There is a better chance of removing in entirety, although there is always a small risk that you might still spill the tumor in spite of trying for removing it entirely. So these two options we put to the patient. So, and to be honest, the patient did not understand the gravity of all what we were talking. So it is
So
just
can I
for
just
it's
say,
of academic
So
interest.
if I can interrupt at this point.
Yeah.
I mean, forget the patient. Even I cannot understand anything right now, because I'm not understanding why are we planning any kind of surgery on this patient, because this is a metastasis, right?
Yes.
So when you say you are going for a cure, I mean, I think very few people speak of cure in the metastasis. There are very few indications where metastatic surgery is curative surgery. The surgery is palliative surgery. What is the point of debulking it? Why do you want to enter if there is no instability? And as spine surgeons, all we can do, we only have two jobs. We have decompression and we have stabilization. He doesn't need stabilization and he doesn't need decompression. We have no job, we have no work.
No, I
So I don't understand what we are doing here, and it may well be my ignorance, but I don't understand what we are doing here.
No, I agree with you. I'm actually saying the same thing, that the indications for surgery in this particular patient at this point are not defined at all. That means that there's no point intervening. What are we trying to achieve? We cannot remove the tumor. He's still in the pre-instability phase. Now, the only thing I can think of is, do you want to percutaneously stabilize above and bypass? So you understand, that means that you just give a palliative structural stabilization and subject him to chemo and radio. Apart from that, there is no indication of any surgery, particularly doing a very, very aggressive surgery when the tumor has already spilled outside, and there is a very high risk of complications which the patient should be willing to accept, because you are still not giving him a cure by doing a vertebrectomy here.
No, but we did not aim for a vertebrectomy. But if we manage to remove the tumor, then the papers have shown that the long-term survival, 5, 10, 15 years survival is better than if we just debulk it.
So Kedar,
why not?
So Kedar, just one question. In this whole process of debulking the tumor, you would be in the process of excising the tumor, you would be leaving a margin, right? So even right now, the patient doesn't have an instability. You might be adding instability only if you debulk or remove the tumor by keeping a margin.
We did this case. Our aim was to remove it en bloc by going into the body and removing all the posterior elements, including a cuff of the muscle and some fascia on top of it.
So stabilization was always a part of the plan.
Correct.
Did you consider SBRT for this patient? Hello?
Radiotherapy. Yes.
Yeah, radiosurgery, because it will have equivalent result.
Not for renal cell. No,
renal cell. If it is those, I don't know the exact chemo that they give, but if it is sensitive to those target molecules, that combined with radiosurgery is going to give equivalent result to a debulking or intraregional surgery.
Yeah. So initially we had this discussion with the oncologist team, and then they said that you try to remove it, whatever is left behind, then we can do the mop up with radiation or chemo.
So Kedar, let's see what you did.
So based on this, we decided to remove it as much as possible, because he was developing some neurology, although not gross. So before that, because it was renal, we did an angiography, and we identified the anterior spinal artery at D9 was the source, right side. We avoided that, and they embolized it pre-operatively one day before the procedure. Go ahead, next one. So that was our rough plan of what all posterior elements we are going to remove. This is the intra pictures of the incision. Just go back. So that biopsy track we confirmed, because the oncologists were adamant that we should do a biopsy to be 100% sure that it is renal met only, because they weren't happy going ahead with it, because they thought there might be something else also. So that's why somebody else had done a biopsy. So we decided to excise it, and we removed it in toto. You can see the cuts through the base of the pedicles at L1 and L2, and all the posterior elements we removed as one mass with muscle and with the fascia on it. This was the post-op X-ray of the stabilization. We went 2 levels above and 2 levels below. Go ahead. And this is he's 2.5 years post the spinal surgery, and 4.5 years post the nephrectomy now. Next slide. And he just sent me a video. He's walking, so neurology is also not a problem. He's not from Mumbai. So, and then a recent PET scan done 6 months ago show that there is no active uptake anywhere in the body. We have not given him any post-op chemo. The oncologists have said that if there is a positive on the scan, then we will decide for any further chemo. So I think this is one of the rare places where it seems around 2.5 years post-op now that the disease has not recurred, and the histology report showed that we had negative margins. The specimen was removed in toto with no spillage of the tumor. I'm not advocating this for every case, but in selected cases, en bloc for solitary metastasis does have a role, I think.
Post-op adjuvant therapy?
Abhi tak not given yet. The oncologists are also following up. In case there is a positive on PET CT, then they have these targeted things ready.
So, Kedar, just one question.
Are you trying to tell me that they gave him nothing? No treatment?
Nothing.
I find that anyway, forget. Because I would think, see, a principle of a metastatic tumor is that if you have a met in any one place, it is by definition you have mets anywhere, micromets, because the met doesn't go to just one place and seed.
Yeah.
They must have covered up with anyway. If you're saying it, they are not. But anyway.
But these are generally resistant to radiation and chemo. Most of the times when there's a body involvement.
No, but they have something else. What they give nowadays, they give stuff. They have immunotherapies. They have a lot of.
Yes, sir. They do start with immunotherapy in such patients.
But Samir, cost was, I think, also an issue for the immunotherapy. It's not cheap, actually, the immunotherapy.
It's expensive.
You should have spent the money on immunotherapy instead of surgery.
So that's why he's running around in a banyan.
So Kedar, just one question over here. You have put a screw in the affected body. So I would be really very, very reluctant to put a screw over there.
Opposite side, where the pedicle was, that we got wherever we thought that the disease is out completely, we put an additional support over there. Because we have not fused it, basically.
Thank you, Kedar. Thank you very much. Next case we have from Dr. Ayush Sharma. Ayush, are you ready with your slides? Thank you.
Yeah. So, So this patient was a 66-year male, and he was a known case of squamous cell carcinoma of tongue, stage 2. If you can see from the images here, he has already undergone a hemimandibulectomy on the right side, and with a radical neck dissection and radiation 6 months back. And he presented to us with progressive quadriparesis. Like within a couple of days, he has really deteriorated with power 3 in all the limbs. With bladder ball is intact, and reflexes are like there is UML signs. All the reflexes are exaggerated. So these are his X-rays, and of course, and this is the CT scan, and of course we can see that the C4 is almost completely gone. These are the MRIs, and and again we can see that the C4 and the C4 of course is involved, and the C5 is also appears to be involved with some soft tissue shadow anteriorly. Posterior looks good, and on MET, what we had was there was some remnant on the primary, and only other the uptake was at the C3 and C4. There are no other metastasis seen at this stage. And these are the axials. You can see there's most of the compression is coming from the anterior. The scorings, as spoken about at this stage, where these were the scorings and these are the treatment goals according to the scorings. For Tomita it was 5, so means midterm with the intra-regional is what was given. And of course the survival and the sin score is 15. That tells that it is unstable. Of course, the whole cervical spine is unstable, and the survival is between 6 to 1 year. So at this stage, what will be the treatment and the treatment protocol? Do you like? What is the opinion of the house? I think because of the progressive deficit and the instability, everyone I believe will offer some sort of surgery. But will you be operating 1 level, 2 level, anterior, posterior, 360 degree? That is what.
Ayush, I'm sorry. I'm very sorry. I got diverted in the beginning. What is the primary and the age of the patient?
So primary is 66 year.
No. Okay, tongue.
Carcinoma tongue, 66-year male, primary carcinoma of the tongue, already has gone hemimandibulectomy. You can see in the images here with a radical neck dissection with radiotherapy 6 months back.
Right. Sorry, I missed that.
Yeah.
Can we get more images, Ayush? We are seeing one sagittal of MRI. Do we have more images?
I'm not put it, but do you anything you want more than this? I thought this is.
If we would have like to see, like all parasagittal sections as well.
Okay, I didn't put it. I thought like it's like everything is coming from here, as you can.
So can I get in Kshitij over here? Is Kshitij around?
From the C3.
Kshitij? Yeah, maybe Mihir can take over. So Mihir, how would you approach this particular case? Surgery is definitely indicated because the patient is going in progressive neurology, but how would you go about this?
Because it's a squamous cell carcinoma, I think it is quite a resistant tumor with a poor prognosis. Have we calculated the life expectancy with the help of oncologists?
Yeah, that's what I told. So between 6 months to 1 year is what we are expecting.
Yeah, so basically it's going to be a palliative surgery, anterior decompression, posterior stabilization, or just a posterior wide laminectomy with stabilization.
Yeah, Srivastava sir.
So one level,
Yes.
one level
so
or both the
in
levels.
this case,
Will you do the other level as well? Was only the C3 or the C4 as well? Sorry, the C4 and C5 both, or only the C4 which is causing the compression?
Now, in this case, if the PET is showing that, this is also getting involved, and plain X-ray actually on CT will also tell you whether there is So this is looking not that bad. So I'll be just restricting here. So posterior fixation and anterior reconstruction, that is to be done after decompression, because neurologically he will definitely improve at present. Later on, if there's a recurrence, we don't know, but a good chance should be given to him. Though the life expectancy is poor, but still.
Both the levels, sir? The C4 and C5, both you will tackle?
No, this I will leave. I will be doing here only.
Only this level.
It said
only
C4.
Only C4.
So anybody for only posterior surgery, considering that the patient has got a life expectancy of 6 months only? Wouldn't an anterior plus posterior be more morbid in this particular case?
Surgery.
I would probably go only posterior.
Yeah. Even I would.
I think the radiation, post-radiation is a major concern in the neck. You don't want any visceral injuries.
Yeah, the other issue is that already there is a commando that's done in the anterior part. The anterior surgery is going to be tough, and if we have a major esophageal injury or something, the remaining 6 months of his life is also going to be a disaster.
I think for me it's a full job. Anterior 2-level C4 corpectomy, partial of C5, because C5, 6, 7 are like a one block. And I don't see that there is going to be a reason that we'll not be able to have a plane between the investing layer of deep fascia and the esophagus. We'll surely get a plane there. We can go from the contralateral side. do a corpectomy C4, partial of C5, put a big plate, expandable cage, and stabilize it with posterior lateral mass. And I would surely lay down cement posteriorly on the lateral mass, because I'm not going to do a laminectomy posteriorly, which will be like a solid fusion mass only. So a complete job, anterior plus posterior lateral mass with a cement layer on the lamina.
Because main compression is anterior. You can
Yep.
see this bony piece is there lying in the canal, and if you leave this alignment, this might fail. So it is better to correct with as Dr. Vishal told, that you will be putting the case anteriorly. I think that can be corrected. So if one is doing, it is better to do it properly. Another thing, neck dissection should not be difficult. Because it has been done from the right side, you expose from the left side, I think you will get a plane.
So, Vishal, what is that cement layer you are going to put on the lamina? Can you
So,
please elaborate?
these are patients who have already been irradiated. One, two, by doing a corpectomy. By doing corpectomy, I'm really worried whether fusion will ensue between 3 and 5 or not, despite the best of grafting. So I'll surely use the best of graft, cage, snug fit plate. However, posteriorly, when I do a lateral mass, my bony lamina is intact. So on my implant, there is this cement overlay technique, which has been described by some Japanese author. I'm not really remembering the name. But what they do is they put in their lateral masses, and on the lateral aspect of the lateral masses, instead of putting bone graft, they overlay cement on the lateral masses, on the lateral aspect of the lateral mass. This leads to a complete fusion there, and this has been tried and tested in occipital also, and also in thoracic spine, where they do anterior corpectomy and posterior overlay cementing, which gives the immediate fusion there. So that's what a technique that has been described, and that's what I have tried in my cases, and it has so far worked well.
So Vishal, just a question over here. In this case, what is the aim of surgery? If the aim of surgery is neurological recovery, won't a posterior surgery only suffice? Because we all know that had it been something like an OPLL, we most of us would agree that we would go in posteriorly and do a long segment decompression and stabilize it. Although this is
Sandeep,
extrapolating the
Sandeep,
analogy.
let me stop you there. Sandeep, for a focal OPLL, would you like to do a posterior surgery? I would not do that. I would do an anterior surgery.
That is a different.
Single vertebral.
That's a different
Vishal,
debate.
what more would you achieve from an anterior posterior than what you would do only from posterior?
So when I do only anterior, I would do decompression, reconstruction, and posteriorly it will give me immediate stability and fusion there.
Yeah, but what we are saying is you do a thorough decompression, a laminectomy from posterior, stabilize, and the alignment is maintained. The prognosis is for 6 months. What more you're going to get from a front back than only what you're going to do from back?
What are you talking about here, guys? Nikhil, what is the morbidity of the posterior surgery putting lateral masses there? What kind of morbidity are we talking about? Absolutely,
Vishal, we are talking about morbidity of the anterior procedure, not the posterior.
So I don't.
Yes. Yeah. I think anterior will be less morbid.
I think it is less morbid if you give absolute stability to this patient, and a good decompression and reconstruction is possible by anterior only. Yes, by doing only anterior, I am worried that the implant may fail, and that is why, to not allow the implant to fail in short run, posterior stabilization is there. And it takes 40 minutes to do 4 lateral masses both sides. So I don't really see a reason we should be worried about.
Time, but Vishal, anterior, posterior, is it not a too morbid surgery for a 6
No, it is not. No, it is not.
Okay, fine.
I would differ on that.
Okay, fine. I think we can move ahead. Ayush, any other thoughts? Samir, Mihir, anything else you want to add in this particular case?
Yeah, I think here the debate is between getting an aggressive decompression into place versus palliative posterior decompression. I think for this particular case, almost both are going to sort of give you equal neurological results, and it's the question of whether you want to stabilize the column, or you believe that the column can be stabilized better by a 360-degree fusion, which I really doubt in this case. Well, there are takers for both. I think both can work, but it's an increased risk that you are subjecting the patient to.
Right. So, Ayush, can you move ahead and tell us what was your rationale behind your treatment and what exactly have you done?
So actually, we have all this discussion, and even team and everyone, and they told like you cannot do both anterior posterior at the same time with this patient according to his other parameters, like he has got to go. So they told if you want to do both 360, which was our first choice, they told do one and then do the second stage, the second surgery. So first stage we did only the anterior, and we could get the plane. We went from the right side and we could get the plane, and we elevated the fascia, and you can see the sutures. We took the tag suture. We took a big incision so that we don't struggle. And this is the intraoperative video. So we use ultrasonic scalpel aspirators for all our tumors because that makes it easy, and let us do the job in a slightly better way. So you can see the whole. This is the C5 body. It was completely like very loose. You can see it is very friable. Like you can easily remove the whole thing. The PLL was pretty thick. As we remove the body, we'll come to know. So just removing the C5, as you can see, it is like a crumbled piece of chalk sort of thing. It was not like didn't have the bony consistency because the tumors were involving. The PLL was pretty thick, so we had to go really slowly and elevate everything from the PLL. The C3 was almost gone. It came out easily. Some part of the PLL was stuck to the dura. So as you can see here, it was very difficult. We are not getting the plane there. So we use the aspirator because then it really comes in handy. The ultrasonic aspirator, you can do a pretty decent job with the aspirator without worrying much about the dura here. So this is the ultrasonic aspirator, which is removing the remnant part of the PLL along with that whatever remnant tumor is there. And I'll just go through it.
You had done the PET scan of this patient before surgery?
Yeah.
Okay. So, and the C5 was involved?
Yeah, C5 was involved. I told you that. So this is the final image, and this is the dura at the end of the decompression. We used expandable cage here, and in the first stage we only did this is the cage, and this is the final picture. Unfortunately, for second stage we could never take him. Like he went through the chemo and everything, and we lost the patient at the end of 3 months. So second stage posterior, which was planned, never happened, and we lost him in just 3 months. There was nothing else on PET, but he had other problems and everything. Nothing related to our surgery, but his blood parameters and everything, they subjected him to chemo again. And that also had some complications. We lost the patient at the end of 3 months. We never did the posterior in this case.
He recovered from his neurological deficit?
Slightly recovered. So from 3, he became 3 plus like 4. Yeah, there was no deterioration for so. There's an improvement of like half a grade to 1 grade at the end of at the end of the surgery. But we just have 3 months follow-up for this patient.
Ayush.
Yes, sir.
Ayush.
Yeah.
This is Mihir.
Yes,
at the end of all this, have we become a little wiser? Would you said that the body was like chalk, right?
Yes, this part of the body, the part which is involved with the tuber, the C5.
Yeah, so perfect. So the C4 body was like chalk.
Yeah.
There was no compression behind the C5 body. Now, do you feel that this had to be removed aggressively, or only a posterior surgery next time you will opt to, knowing that the consistency of this tumor is like a chalk? Hello?
I see, it's very difficult what you got intraoperatively, but looking at this, most of the time out of 80 times out of 100, I will go anterior. That is what I feel.
So no, Ayush just...
Of course, you can say that, and retrospectively, we can percolate whatever we had. But there's significant, the tumor mass and the PLL, as you can see, it was compressing the dura. If you can go back to the video, look at the consistency of the cord. You can see see this cord and see this cord. You can look at the consistency, the consistency of the cord, and you can say that definitely there was significant compression happening at the proximal part of the cord. Just look at the video and you can make out. And this was completely stuck, the tumor, the PLL and everything. Although the consistency of the body is what it is.
So Ayush, my question is, especially in tumor cases, there's a lot of vascular element which is involved. It's not like tuberculosis, right?
Yeah.
There is a lot of endarteritis which can cause ischemic sort of affection of the cord.
Yeah.
So the only question is that had this patient survived more than 3 months and you would not be in a position to do a posterior surgery, probably this construct holding on in case of an osteoporotic bone with an expandable cage, a long segment, I would really be very, very cautious. As Mir said, I would always go in posteriorly to stabilize.
We always
Exactly. Sandeep. Exactly, Sandeep. I echo this. Exactly, that is the reason. On one hand, I would be aggressive on decompression part for the neurology, knowing that patient is going to survive for 12 months. But I would surely want to stabilize posteriorly with the concern that you just mentioned.
I agree with you. And that's what was our plan, that we planned because of the constraints we had. We didn't want it to have a very long surgery. We didn't know how much we'll struggle with one stage. Doing a 20, 30 minutes, you can say.
So Ayush, just one question. Why an expandable cage in this case?
Yeah, because it's a tumor. I always prefer a mesh cage for any other surgery, for OPLL and everything. Tumor, it doesn't, like, you're not looking at the survival rate of 6 months. I'm not looking at a fusion happening. So you want to do a quick job. You want to avoid the complication. It just saves you 10-15 minutes of going and trying that case. Other than that, I'm fine with using a mesh cage. And my first preference always a mesh cage, not expandable cage, other than a tumor.
Yeah, I think
I'm Dr. Dalvi. I have a couple of questions. You put what did you put there? Bone graft or something, or you didn't put it?
Yeah, so we used the allograft. We didn't put like a combination of.
My next question is on the CT and on the MRI. Were the lateral masses and the posterior elements involved by the tumor?
They're not involved. Not involved.
So my question to all the people who are shouting so loudly about posterior is, why do you need to do posterior for this patient when the lateral masses and the posterior elements are completely intact? And there is an anterior, whatever osteo, if it had failed, if it was going to fail, it would have failed straight away.
So Samir, if you go and look at the CT images, if you can just, if you look at this CT images, I'm not very sure that the posterior elements are not involved. Look at the intensity changes between the C3 and the C4 lamina. I mean, it doesn't
posteriorly, and there's nothing happening here except for this. And PET also, they didn't tell us that anything is they're picking anything.
This is a pure vertebral collapse. Most of the weight, so this is not the lumbar spine, this is the cervical spine, where a large proportion of the weight is taken through the lateral masses and the posterior elements, which are completely intact. And he has done an anterior load sharing construct with a buttress plating. So I don't know why you should scream and shout that this is going to fail.
Yeah. See, this patient, if he had a longer longevity, I would have probably gone posterior. Otherwise, for 6 months, it's not going to fail. Because if you don't do a proper and get a proper fusion through the expandable cage, if the patient is going to live longer, then you can go posterior and put bone graft. So I am also against doing posterior in this case. I was wondering actually why this discussion also came up of going posterior.
No, I think what we are missing here is a neck dissection and irradiation. I think a good assessment of his trachea, esophagus, because there are lots of complications going anteriorly as well.
But we had the same team which has done so we have very good oncology team for neck from the ENT department, and
perfect.
The same team was there with us. So we had them on board, and they knew exactly what they had done. So we were very confident we won't have a problem like that, because they do it regularly, and that was the team which has done the first surgery.
All right, guys. Thank you, Ayush. We'll move to the next case. Thank you very much, Ayush. Nice case.
I'll stop sharing.
Amandeep, are you ready with your presentation? Next case will be presented by Dr. Amandeep Gujral.
Sorry, wasn't 9 o'clock Dr. Boriani's time?
So he's joining at 9:30.
9:30.
Yeah.
Amit.
Yes, sir.
I'm just into poor reception, so I'll have to log in again. Amandeep can continue.
Okay.
Can you take my calls?
Amandeep, please go ahead.
So I'll be presenting a rare case of a follicular dendritic cell carcinoma. I hope all of you can see my screen as well. FDCS is the first time I'd heard about this terminology while dealing with this patient. So I'll just quickly share the patient findings. So she was a 43-year-old female with progressive axial pain and a left leg radicular pain since 2 months. And since 1 week, she started having a painful left foot weakness that was subjective around 3 to 4. She had a walking, standing, and sitting claudication as well, and walking distance was around 5 minutes. And she also started noticing a frequency and urgency in her maturation as well. She had a history of undergoing a lymph node excision in 2010, and again a cervical lymph node excision in 2013. The biopsy of the first one was Castleman disease, and second was inconclusive. The X-rays are shown over here. As you can see, there is a ballooning of the anterior cortex as well of the L4 vertebra. There is a winking sign, so the left pedicle is also involved. And these are the CT scan images, where you can see there is a breach in the cortex continuity, and the lesion is in the whole of the body and the left pedicle. Should I wait here for questions or should I proceed?
No, I think we can. Yeah.
MRI. Yeah.
So this is the MRI images. You can see it's a solitary lesion only involving the L4 vertebra. There are signal intensity changes seen, and the surrounding soft tissue looks quite nascent. There is no changes in either the psoas muscles or the small epidural collection. But apart from that, everything looks consistent or only involving the osseous part of the L4 vertebra. So we decided to do a CT guided biopsy for this patient. It turned out to be inconclusive. They just reported as a round cell tumor. It can be a lymphoid tissue. The IHC was inconclusive. We went to our oncologist team as well. So either should we proceed with chemotherapy or radiotherapy, or should we do a surgical excision for this patient? So their suggestion came that based on this biopsy report, they cannot say whether it's a radiosensitive or a chemosensitive tumor or not. And going by the surgical team's experience as well, that it is instability, as you can see on the X-rays as well, where the pedicle is involved. So, and with
so Amandeep, can I just interrupt over here? I would like to ask Srivastava sir, where a CT guided biopsy is probably not very conclusive. They have just mentioned query lymphoid tissue. So would you actually go in and attempt a biopsy again to establish a diagnosis and then take it further, or instead of contemplating these further treatment protocols?
Actually, most of the time in such type of lesion where the CT, which has been done, it shows clearly involvement of even the pedicle and half part of the body on the left side. I think we usually go for pedicular biopsy, and the spine surgeon, they should themselves do it. So you get a good chunk of tissue, and the possibility of getting the histopathology report is better. What I feel in that way. So that is the one option of doing J needle biopsy, and the amount of tissue which you get is better. Sometimes what happens, you get a very small tissue, and then you have so many places to send, which and where you are going to send which one, it is very difficult. So it's better to get a good chunk of it, and I think that might show positive. This is
So,
just
Satyan, are you around? Hello, Satyan.
Yeah, Amit.
Yeah, Satyan. So we have a one side deficit neurological involvement with an extensile lesion showing some sort of left side compression also on the nervous tissue. So how would you like to go ahead with this kind of presentation, where we have this solitary lesion involving the L4 vertebral body?
Yeah, I understand our excitement to go ahead and do an excision and get this tumor out. But sometimes these tumors are very sensitive to chemotherapy, and you may not need to do anything. So without doing a biopsy, without getting a conclusive biopsy, going in and operating, I think should not be done. And it's better that if he's not got a conclusive biopsy report, then as Dr. Srivastava said, I would do it myself. Take a white bore needle, a Cook needle, and do a transpedicular biopsy and give him the report and get the report. Failing which, then if yeah, then the surgery can be considered.
Like to
Can I
ask
can I
ongoing deficit. So how many amongst us would still say ki with an onset of early urology complaint and a deficit in the neck, we again do a biopsy and not do an open biopsy?
Yeah, if it is a
No,
myeloma or
see,
something, na, this can, they are very chemosensitive, and you don't need to do any surgery. They will, it all dissolves very well with the chemo. So getting that biopsy is very essential.
Okay. So you would keep myeloma in your differential for this patient.
Yes, I mean, I'm saying that I need a biopsy before I go in and operate.
Okay. So should I continue here?
Yeah,
Good,
please go
Amit,
on.
please.
Mir, is Mir around?
Yeah,
Mir?
I'm there. I'm there.
So any thought process on this as to why you did not attempt a biopsy again, or what's your
No, the thing,
reason for going ahead?
see, the thing is that the patient was already developing a sort of a cauda equina syndrome. So the question is whether we do a true cut biopsy versus a CT guided biopsy. The problem was not getting the tissue. The problem was that they could not do an immunohistochemistry typing. They got the tissue, but they could not characterize the tissue. Now, whether that was really possible using a true cut biopsy or not, I do not know, because the answer to this question was after the surgery. And like Amandeep gave away the sort of heading right in the beginning, I don't think that tumor was possible to pick up even with a true cut biopsy. I don't know.
Okay.
Really.
So one question: awaiting biopsy, if there is a patient having a deficit, can you manage for some time with steroids?
That's a very debatable thing, isn't it, Arvind? That means it's individual. So if you have a lymphoid tumor or a myeloma, they may better themselves. But most of these malignancies do not do well with steroids as well.
actually, steroid does help. Whatever the lesion is there, little bit of the edema part, it is taken care of, and at least you are trying to protect the thing. How much it is going to really work, we don't know, and ultimately that is not a treatment of choice.
To buy time, sir.
Yes, to buy time, and I think this is helpful. That is not contraindicated.
Okay, Amandeep, can you just tell us what you have done?
So PET scan was also done, so it showed no primary elsewhere in the body. So differential, as others have also pointed out, it might be a myeloproliferative tissue, multiple myeloma, a metastatic, or a primary tumor. We classified the tumor according to Weinstein surgical grading system, where it came in grade 4, where there was a pedicle involvement in the body involvement and a breach in the cortical breach as well. So we ended up doing a transperitoneal approach, L4 vertebrectomy. Pre-operative embolization was done. The options were either we do a piecemeal or a R-block dissection. We felt that doing a R-block dissection or removal at L4 with the cord, the precious nerve root, and the vessels anteriorly would be quite difficult. So we went in for a piecemeal one. And again, with the histopathology report, this time on the IHC reports, they were able to classify it as an FDCS. And these were the findings on the histopath report. Now, we did do annual follow-ups in this patient each year. At the first year, there was no recurrence. At 2-year follow-up, a patient did had a multifocal recurrence. So there was one hotspot in the left parotid, and there was a smaller hotspot of around a centimeter or so in the left psoas. Now, the radiologists have classified this as a chemo and radio resistant tumor, but then again, they were of the opinion, let's give 16 cycles of chemotherapy. Now, with a centimeter of hotspot in psoas abscess, does anyone has any other take on it? How to proceed?
So Kedar, are you there?
Kedar, he was not actually at house, so he might have gone.
Okay, Kshitij is around. Kshitij.
Hello, I'm here.
Okay, Kedar, please. Yeah, so there is
I just lost reception. I was in bad area. Can you just Is this a solitary lesion, right?
Yeah, Amandeep's concern is a recurrent lesion in the psoas muscle about a centimeter diameter.
Okay.
Yeah.
Okay, now the concern. I guess the only option here is, chemo and radiation. I don't think there's any role for surgery if there's a recurrent lesion there.
Okay.
Can I
And
say
why
something else?
would you be? Yes, sir. Please go ahead.
Yeah. So see, it is an FDCS. It's a dendritic cell sarcoma. So the most important thing here is that if you see this recurrence, the parotid gland was the primary site of this tumor, and it presented after the first surgery was done for the spine. Now the primary source of this tumor has been the parotid. And if you listen to the history of this patient, right in the beginning, the patient had had a biopsy of a posterior auricular lymph node, which was termed as a Castleman's disease. We will tell you what that is later on. But that is supposed to be a pre-malignant situation. So that pre-malignant situation 10 years back started this whole process. Then the patient presented first with a spinal met, then with the primary in the parotid, and then with a recurrence again in the spine. So the tumor has been sort of walling around and never seemed to be in control. And it is all chemo and chemosensitive and radiosensitive pattern is not there because it's a sarcoma.
So Mihir, it was not picked up on the initial PET scan, if I'm not wrong.
No, the PET scan was reported normal. So there was no primary.
Okay.
Yeah. So the second PET scan picked up a large parotid gland, which was treated with chemotherapy, but it was chemo resistant. So they had to. Amandeep, can you go ahead?
So during this follow-up in the third year, the tumor size has increased to almost around 6 by 8 by 9 centimeters. You can see the almost whole of the psoas is involved now. On the X-rays, you can see there is the lower or inferior edge of the L3 is also irregular now. It is also showing signs of involvement. There is implant failure. The cage is loosened up. The rods have broken on one side. And truly you can see it's reaching up till the L3 pedicle on the left side. Yeah, so this is
so Amandeep, what is happening to the parotid area after 3 years?
So it's the same thing. So it also increased in size. There was a massive increase even after 16 cycles of chemotherapy. One chemo team, onco team had said that it is radio resistant, but still they wanted to try their luck. They started with chemotherapy. 16 cycles were given. At the end, he went in for a parotid excision. And post that, he started having flare-ups in his spine issues as well, where the pain had increased and the discomfort had also increased. So we got the X-rays done, and this is what the latest X-rays at 3 years of follow-up had showed. And this is what we had to do.
So what's the life expectancy depending on the parotid treatment?
This was really a kind of a yorker or a googly for us as well. Because as I had said in the initial, when I started my presentation as well, FDCS is something that this was the first time I'd ever heard of it, along with Castleman. So we did some literature search as well. So 2/3 of the cases are seen in lymph nodes. Extranodal sites are very rare, and it's mostly seen in soft tissues. The only case reported for involving the spine is seen in this case. In this case, where it was only seen in the epidural space, there is no case where any osseous involvement has been seen. 10 to 20% of cases are from Castleman disease. It's a pre-cancerous stage. The local recurrence rate is as high as 40 to 50%. And life expectancy you can all gauge from that. It's quite an aggressive tumor. So the last surgery was done, I think, almost 4 months back. We are still in touch with the patient. He is recovering well, and we just I'll keep you updated regarding the same.
So just one basic question: how do you actually diagnose this particular condition on histopathology?
They have these markers for it. I had shown it after the first surgery. So these are the IHC reports where they use these 5 markers for it: the Faston, CD21, 35, epithelial membrane antigen, and clustrian. So based on these markers, they diagnosed it as FDCS.
Amandeep, if I may ask question, what was the indication for the second surgery? What was the patient's complaints?
Actually, what has happened is that the oncos resected her parotid gland and did an extensive neck dissection. Now the patient had an increase in the retroperitoneal tumor, which was sort of bulging out the psoas. The patient had started developing severe intractable back and radicular pain. She was hardly able to get up from the bed. She came on a wheelchair, and there was early buckling. That means that the knee had started to buckle. Now, whether that was because of the instability or because of the tumor, it was almost impossible to say. But the oncos were saying that in case you want to give a radiotherapy for a sarcoma, then you'll have to remove that sarcoma. You'll have to debulk it to the best possible extent. Otherwise, it is useless to give radiation to the sarcoma. So we discussed this with the patient, and the patient said, look, I cannot give up. I want a surgery. So they came back to us, and with all the risks explained of all the recurrences and all the possible complications, we went in and operated.
And did it bleed a lot?
No, it was embolized very well. The total blood loss for the anterior and posterior was about 1 liter.
The one thing which looks very good here is that alpha S1 fusion at the facetal area from the previous surgery. So that's why that those, even after all this, the rod broke, but the S1 screws are still holding up nicely.
No, even when the cage tilted, there was a solid fusion through the cage. You know, we really had to break through that and get that cage out, which is almost a nightmare. I think all of us have experience of that by now.
Mir, if I may ask one more last question. For the first surgery that was done, do you think doing this entire like corpectomy and this wide excision and all has made a difference to the outcome? Or if you would have just done a decompression?
You mean to say an R-block excision?
Yes.
See, the problem is, in literature, the whole thing is that the R-block is good, but sort of explaining a 43-year-old about the complications of R-block, which you have to, when you are going to deal with an R-block, explaining to her the complications of R-block, the whole discussion always leads to, when you go to the complications of death and neurology and start telling them about vascular repairs and all, this lady was totally out of it. There was no way she would give consent to all that.
Thank you, sir. Thank you very much. So we have Dr. Saijot Raut. He missed out on his presentation during the last clinical meeting. So, and we still have some time, I think, left. So, Sai, if you are ready with your presentation, please go ahead. We'll utilize this time.
Yes, sir. So can you see my video, the screen?
Yes, Sai, go ahead, please.
So this case is a, good evening everyone. This case is a L1 compression fracture, is a trauma case, which we missed out on the last time. So the 63-year-old male, he came to us with a history of fall and he had a back pain.
Sai, 1 second. Can you please enlarge your, put it in the presentation mode?
Sorry?
Can you put your PPT in the presentation mode? Because we are seeing the very small pictures here.
Slideshow.
Yes, thank you.
So a 63-year-old male came to us with a history of fall. He had complaints of back pain. He had tenderness over L1 region. He had no radicular pain. He was non-ambulatory and on examination his neurology was normal. We went ahead and did a X-ray, MRI, and CT scan of the patient, and we saw that there was a L1 fracture. On CT scan, we saw there was also a right side lamina fracture. So we went ahead and we saw that it's a type of a chance fracture. So we decided we'll go ahead with the treatment plan. So what next? In such cases, in a traumatic spine, what do? We conserve this patient or fix this patient? If you have to fix, how to fix long or short segment? Is interfragmentary screw mandatory in such cases? Do we decompress in a normal neurology patient? That would like to ask here.
So can you just go back to the images, the X-rays and the CT scan?
So this vertical fracture is not a chance fracture. A chance fracture is through and through.
Yes, sir. It had a right side lamina fracture, sir.
So lamina fracture is not chance fracture. It is
So how do we?
horizontal fracture.
So can we go to the X-ray? Do you have the X-ray?
Preoperative X-ray was not was missing in this case, sir.
So with a patient with practically no neurological deficit, with a L1 fracture, which on the X-ray might not be looking too ghastly, what made you go in for an MRI and a preoperative CT scan?
Sir, we did an MRI to further evaluate MRI. We saw if there is any fracture. So CT cuts were taken, which we saw a lamina fracture. So we did a CT scan also.
Okay, any questions for?
Primarily what we see here that there is a fracture of the posterior superior corner of the L1 vertebra.
Yes, sir.
There is some wedging, and that there is some I don't know whether it's hematoma or something anterior to the spinal cord at the level of the L1 and L2 body with no deficit, correct? And
yes,
there is a fracture of the lamina in the at the level of L1.
Correct.
So Sai, I think we should have put up preoperative X-ray because that was very important,
Yes, sir.
So then probably we would have guessed as to why you have gone ahead and then did a MRI of this particular patient, 63 years old, no neurological deficit, L1 fracture.
And it's a fresh fracture, right?
Yes, it's a fresh fracture. So we went ahead and did we did a one level above and one level below and two level interfract screws, sir. And we fixed the fracture. No decompression was done in the initial stage of the surgery. The first surgery, there was no decompression, only we fixed the fracture and we came out, sir. Post-operatively, patient was doing well. We mobilized patient with walk. He was comfortable and was discharged. Patient came post-operatively 10 days back with inability to walk and he had right side foot drop. So we went ahead and saw, we had a doubt that what went wrong. So we did a post-op MRI and CT scan for the same. Post-op MRI showed there was no, the screws were placed properly. There was no compression at any level. We saw CT scan cuts also, the screws were placed properly. We couldn't find any reason for the neuro deficit, which was post-op 10 days. We went ahead and did again a radiograph post-op 15 days where we saw there was some collapse at the fracture site. The collapse was seen in the X-ray post-op 15 days. So we still did not find the reason for the neurological deficit. So we went ahead and did a EMG NCV for the same. And EMG NCV showed some chronic motor axon degeneration. Patient was not happy with the EMG NCV. He repeated the EMG NCV. After 15 more days, patient post-op 1 month, his neurology started worsening. The right ankle and knee was grade 1. His left ankle and knee was grade 4. Bilateral hip was 3. Sensations were intact. Reflexes were normal. So we again post-operatively 1 month after the case, we did an MRI, repeated an MRI. We saw this picture on the MRI, post-op MRI 1 month. We saw there was some compression on the MRI. We also saw there is a slight changes in there was a hyperintensity over the lower end plates. So in this case, what went wrong, we did not know. So we went ahead again for the next step of the where we went ahead and we did 2 level above, below with immediate 2 level above and 2 level below fixation, and we did a total decompression at the fracture site. After this was done, patient post-op day 10 of the second surgery, his neurology started improving. He started doing better, and now he's on physiotherapy. Patient is started mobilizing. He's walking with support, and he's doing better than the second surgery. So we don't know what went wrong. There was
which
no
kind
neurology.
of decompression was done, Sai, this time? Was it a laminectomy, or did you go anterior to the spinal cord and try to remove that retropulse fragment as well?
No, sir. It was a laminectomy.
Laminectomy only.
Yes, sir.
I wish you had done a CT the second time, because this case is very funny.
Yes, sir.
I am not understanding why he got the deficit actually.
That's what, sir, we were trying to find out what went wrong in the first surgery. Why was the deficit there? Because we tried to do an MRI first time because the screws were placed in place properly. Also, we saw there was some loosening in the screws, where there was at the L2 when there was loosening in the screw, which again we sent a biopsy for the same, but there was no sort of infection or anything in this from the biopsy.
Because then what did you go? What I don't understand is that I understand that his neurology was going down, but
yes,
what did you go in for at this time? I mean, what was your diagnosis? I mean, if you I mean, you need to document whether there is compression or there is poor fixation, instability. What are the issues? Did he have back pain, or he only had this neurology going in the legs?
He had some. He had back pain, sir. That's why, and he had the neurology was going down. Plus, we saw the fracture which was collapsing, and that's why we thought we would go and see if there is the MRI, next MRI, which was post-op MRI 1 month, which was second MRI. Some question. So we went ahead and did the second surgery.
Okay. I would have done a CT. I would have done a CT, and I would not have put a screw in the. I would not have put a screw in the fracture.
When you went and you did the laminectomy, and that time, what was this? You saw that it was significantly compressed?
Yes, sir. There was some kind of compression.
Compression from where, Saijo?
At the L1, sir, there was L1, the retro pulse fragment was compressing the cord. So we did a laminectomy, wide laminectomy, and then we fixed 2 level above and 2 level below, and then we came out.
Why I'm asking this because you have shown that there was a fracture of the lamina.
Yes,
remember,
sir.
You had told that there was a fracture of the lamina. So was it impinging significantly from behind also and from front also?
No, sir. No, sir. The lamina was not impinging.
Okay. I think we should wind up over here. May I invite Uday to take over the proceedings from here on? Uday.
So thank you all the members for the wonderful cases. The icing on the cake is going to be Dr. Boriani's talk. Welcome, Dr. Boriani, from all the Bombay Spine Society members. Dr. Boriani actually needs no introduction. Everybody knows him. He's a giant in spinal oncology. Many firsts to his credit, and he has helped immensely develop the spine oncology surgical as a specialty. May I please invite Dr. S K Srivastava, sir, our president of the Bombay Spine Society, to give a warm welcome from all of us to Dr. Boriani.
A very good evening to all of you. We welcome Dr. Boriani to our BSS meeting. This is Bombay Spine Society quarterly meeting, and we are very happy to welcome you, sir. And we wish that we get extra insight in malignant cases, the metastasis, and your talk is going to enlighten us. You are most welcome. And on behalf of Bombay Spine Society, we are giving a very hearty welcome to this society meeting. Take over. Uday, you kindly take over the proceeding.
Dr. Boriani.
Thank you. Thank you very much for the invitation. I'm very, it's a privilege for me to be here with you. I try to share the screen. Let me see if it works.
Yes, sir.
Yes, sir.
Yes.
Can you see my?
Yes, sir. Yes, sir. Please go on.
This is not the first. This is the last slide. Okay. You see the first slide?
Yes, sir. Clear.
Okay. Great. Great. So I'm really very, very happy of this invitation. I thank you very much for this. It's nice to meet you. And even if it is not possible to be in front, let's hope that in the future we will meet directly after this bad time. So let's start. this presentation. I would like to ask you to interrupt me anytime if there is any question, as otherwise the risk is that I have not the feeling that you appreciate my talk, or if there is something that you want to comment or question, please do not hesitate to interrupt me. So these are my disclosures that are not affecting my talk. Let's go. Why it doesn't work? Okay. So the talk concern bone metastasis in the spine. And I must introduce myself telling that since 40 years I'm working on spine tumors. I started working at the Rizzoli Institute for many years, which is a major center for bone tumors. And there I was the one who was charged to work on spine tumors. That's the reason why I had the opportunity to study, to see, to treat more than 2,000 cases in these many years, and half of these are metastases. This is a very important point, as my major activity was on primary tumor, and it is very important to remark that both for primary and metastatic bone tumors in the spine, we have always to rely on three major points, which is diagnosis, first to differentiate between primary and metastasis, then staging. It means to standardize our treatment according to the behavior of the disease, and the treatment itself that must be multidisciplinary. The first point that is very important to remark concern epidemiology. And we know that metastases are much more frequent, but sometimes we don't forget that there are 300 times more frequent than primary tumors in the spine. This is coming from the numbers that we can take out from the epidemiology, but I don't think that this is major interest at the moment. The second point is that the surgery for metastasis is palliative. What does it mean, palliative? Palliative means that our target is to improve the quality of life by restoring stability and motion, by prevent and treat neurological problems. But only sometimes we have to resect the tumor for local control or for oncological purpose if there is no other possibility to approach to the disease. Conversely, the treatment of primary tumor is absolutely different. It is not a functional treatment. We have to resect the tumor most of the time en bloc or according to the oncologically appropriate. This means that the functional point is not so relevant. It means that to achieve a correct treatment of primary tumor, sometimes we have to give up to delete some function. This is a very important point. It means that primary tumor are much less frequent than metastasis, requires a different treatment, completely different treatment, so that must be suspected. It is a disaster if we treat a primary tumor as if it were a metastasis. So the first point in this talk is a reminder that diagnosis must be always sure before deciding the treatment. And how to do this? So first of all, we have to work on the physical findings, to know the patient, his clinical history, and then imaging, and finally the biopsy with the tumor histotype, which is what deciding. The imaging is very important as we can understand really a lot of things about the disease. The pattern of bone involvement is very important. Most of metastases are lytic, about 90%, but only 10% are sclerotic. So sometimes we can have sclerotic osteoblastic imaging coming from osteoblast activity from tumor cell reseal factors. For another point is 95% of bone metastasis in the spine arise in the vertebral body, only 5% arise from the posterior part. So when we see a tumor coming from the posterior elements, so we should not think first of all of a metastasis, but maybe this is one of the few cases of primary tumor. So at the end, biopsy most of the time should be performed. Maybe we can avoid it if the clinical finding, the imaging, the lab tests are very strongly suggesting, for example, if the imaging is coherent with the metastasis in a cancer patient. So we must know, as I told before, which is the typical image of a metastatic disease. Some lytic lesion with a specific lab test can be consistent with myeloma, so biopsy can be avoided, or some kind of primary tumor as a really pathognomonic image like osteoidosteoma, hemangioma, aneurysmal bone cyst. Let's see some examples, some case. For example, let's look at this case. This is an 81 years old patient I saw some weeks ago. He had the back pains only since 2 weeks. So we can see the CT scan where there is a lytic and blastic lesion infiltrating and swelling the ribs and the costovertebral area with invasion of the vertebral body. Then we perform a CT scan of the lung and we see that there is a tumor there. So we have finished. We think that the result is a lung tumor with a metastatic disease in the spine. So maybe it is important to perform a biopsy in any time. And so the result is that it was a prostate cancer metastasis. And today, it's very different to treat a prostate cancer metastasis rather than to treat a lung cancer metastasis. But this will be concerned later on. So it's very important to have a fully achieved diagnosis. Let me see how it works. Okay. This is another case. This is a fully lytic disease with a pathologic fracture. There is no bone formation, and there is a huge tumor invading the canal. And if we perform, you see an immunofixation, then we see that there is a lambda, EGG lambda, and this is consistent with the diagnosis of myeloma. And so in this case, biopsy is not mandatory. Maybe we should perform a biopsy in the iliac wing just to understand if it is a disseminated disease or not. In some cases, for example, a painful scoliosis, you know that scoliosis is never painful. In the adolescent, when it is painful, we should suspect an osteoidosteoma, and the isotope scan will find the exact location, and then a CT scan will show the typical image of an osteoidosteoma. So in this case, biopsy is not necessary, as we have all the elements for a diagnosis of osteoidosteoma. Also, this case, it's easy to be diagnosed as an hemangioma. It's a lytic lesion, with this no infiltration, with a good margin. There is this spot of ossification, which is a typical column aspect. And so this is consistent with the diagnosis of hemangioma. And so we can do a vertebroplasty. Maybe at the time we can do a biopsy for confirmation. But I think that it is really pathognomonic for an hemangioma. This is an MRI showing a typical multiple bubble with double content inside it, with a combination of membranes and liquid. The margin is very sharp, so it's quite consistent with a diagnosis of an aneurysmal bone cyst. So in cases like this in the past, we started with embolization. And if the answer, the response to embolization is good, we even do not perform biopsy, maybe only later. I think that biopsy is always very useful. But in this case, I think that we have a very high suspect that it is an aneurysmal bone cyst. And after just repeated embolization, we can achieve a good healing. So let's start about the treatment. The treatment of metastasis is palliative. Palliative means that we must preserve the function. or maybe sometimes even more aggressive treatment is allowed. But our target in any case is to improve the quality of life. And we agree that the indication to surgery is neurological symptoms, instability, pain, untreatable pain, failure of previous treatment. But the point is, which is the best treatment strategies? There is no agreement. There is a lot of different staging, different approaches. And it's always a very important question. My mentor, Professor Campanacci, always reminded that we should avoid a too shy treatment, unable to get a local control, but we should also avoid a too aggressive treatment, which is exposing the patient to unnecessary morbidity. So we have to balance our aggressiveness towards the real behavior of the disease. But we should never forget again that some of these patients will survive longer. And so we should not only decide timid, shy treatment, mini-invasive, as many of these patients, about 25%, will survive more than 2 years. And we have cases where they survived the 5, 6, 7 years with a lot of local recurrence. And this is negatively affecting the quality of life. So the sentence by Professor Campanacci was written more than 40 years ago, but the same question you can find in the actual literature. This is a very interesting paper where the same question is approached. As the question is, a morbid operation in a patient who is unlikely to survive would be inappropriate, but conversely, avoiding surgery when a patient could benefit would be equally incorrect. So we must understand, we must have some kind of prediction to understand how the patient will survive, how they can survive, which is the best treatment we can approach. And in this paper, they studied a large number of patients, more than about 1,500, prospectively collected, and they applied the different scoring systems that are reported in the literature. And all these scoring systems, which are very famous, are very widely used, but it is surprising to conclude that are not reliable enough to predict the survival, that they are useful, that can highlight the factors that influence the survival and should be taken into consideration. They are very useful when you want to study a large number of patients, but for daily activity, in my mind, and also in the mind of the author, are not enough reliable. And so what do we do? What is our approach? Our approach, once achieved the diagnosis of metastasis, is to stage it, to categorize the different kind of patient by patient, and in a multidisciplinary approach. It's very important to have a tumor board group where the different specialty can approach and decide which is the best point. In our system, we consider the systemic condition of the patient. We consider the diffusion of the disease, that there is oligo, multi-metastatic disease. So we must consider the first point is systemic. The second point are the neurological symptoms, neurology. The third point is the stability of the metastasis. So it's a mechanical point. And then the oncological feature of the metastasis, the sensitivity to radiotherapy or the new medical oncology target treatment. It is very important to read the literature, to have contacts with the medical oncologist, as every day there is a new drug, very powerful, very effective, and surgery sometimes is not useful as this treatment are. So these are the 4 points. So systemic, neurologic, oncologic, mechanical. Most of you will remember that NUMS is the system that they use in New York at Sloan Kettering, but it's also the system that we use. We published this system many years ago in 2004, but we were using since 10 years before. It looks like complicated, but really it's not. It's just a flow chart that I will try to show you step by step. Then we first consider the systemic feature of the disease, the neurological point, the oncological feature of the metastasis, and the mechanical. And based on this point, we will decide the best treatment. And this is the NOMS. You see that there are the same 4 points, and this was published in 2013 after more than 10 years activity by our friends in New York. And while our major target is focusing on surgery, they are mostly focusing on radiotherapy and the combination of the radiotherapy with the separation surgery. But what is important to say that in 2 great centers of bone tumors, we have arrived to the same conclusion that these 4 points are important without any communication between us. So we were working, we were meeting together, but we have not done this together. We have arrived to the same system from different considerations. And even the literature say that these are very important points. The systemic condition and the nutritional status are considered very important on a multivariate analysis. The age is very important. It matters in the decision. It is obvious. It affects the nutritional status. And it's very important, this study on 1,300 cases, prospective or observational, that show that poor performance status at presentation is significantly and independently associated with poor short-term survival. This is a very important point. So if the patient is not in good condition, that we must consider this patient will not have a long survival. And conversely, the number of disease, the number of metastases is very important. The few metastases are associated with longer term survival. And these are a concern we have there would be a very long discussion about the concept of oligometastatic disease. What does it mean, oligometastatic disease? It's been decided, it's been defined as a disease where there is only 1 to 5 spine metastases without any other systemic disease, or only 1 spinal metastasis less than 5 systemic disease, and polymetastatic when it is more diffused. And the idea is that oligometastatic disease is intermediate cancer state of limited metastatic capacity, and so the prognosis is better. And maybe you know that there are 2 major theories not yet defined, not yet decided which is the best of this cancer spread. The Alsted theory, which is the oldest, did say that the cancer spread is extending into continuous fashion, so the radical tumor resection are believed to be curative. But against this hypothesis, there are the systemic hypothesis, means that those who believe that this is important, that the clinical apparent cancer is just a systemic disease. So it means that the local treatment has a limited role. So these are 2 opposite views of the treatment. But according to this study published recently, that oligometastatic theory say that ablative local therapy is highly suggested for this patient. This is demonstrated by this figure. Here you see that in patients with oligometastatic disease, there is a significant survival advantage at the 2 years mortality with those with polymetastatic disease. And if you consider only 1 metastatic disease versus more than 1, it's really even more statistically significant. So the less number of metastases, the longest survival. Another point is the oncology, the oncological feature of the metastasis. In most of the paper that you read, they are focusing on all bone metastases in the spine. But we should consider that every metastasis is different. Lung metastasis is different from liver metastasis, is different from renal cell metastasis. And this is a differentiation that is becoming more and more important the more genetic basis of disease are considered to understand the molecular drivers of tumor proliferation. And so this allow the development of drugs specifically targeting the molecular pathways. This is very important, especially for lung cancer, that it has been demonstrated that there is a different result. The target AGFR mutation may provide an argument for more definitive surgical treatment as the medical oncologist as a more powerful weapon to address it. The other point concerning the oncological feature of a metastasis is radiotherapy. We know that surgery plus radiotherapy is superior to radiotherapy alone, and this is one of the few evidence-based indication coming from the literature, from the old paper written by Patchell many years ago. But today, there is something that is changing. This was a literature review that our group performed many years ago together with the Delphi consensus opinion, and the result was the compression surgery and the instrumentation is the best treatment of spine metastasis with epidural disease. So it's a point that we should always remind. But we have today two different options with radiotherapy. I'm not a radiotherapist, but I support the idea that we must work very, very close to them. So conventional radiotherapy is safe and effective for radiosensitive histology, but today we have radiosurgery. We have the possibility to address in a very close area, very high doses of radiation. And so the concept of radio-resistant histology is losing importance as this kind of small fraction radiotherapy is becoming more and more important. So this stereotactic radiotherapy is very important, but has two major limits. Epidural tumor cannot receive the maximal doses, and the vertebral body collapse is a risk. And so it means that we must stage the tumor expansion in the epidural space. And the Bilski scale is very important for communication between us and the radiotherapist. And the concept is that in Bilski 3, the radiotherapist will not be able to deliver the maximum of radiation in the epidural space, which is compressing the cord, which is too close to the cord. And so the combination with the surgery will be very important. And this is the theory at the Sloan Kettering, where surgery is reduced to be just a separation treatment, just something to create a safe zone between the neurological element and the rest, the rest part of the tumor, which can be treated by stereotactic radiosurgery. So it means that the idea is that stereotactic radiotherapy is so effective that surgery do not require to remove completely the tumor, just to create a safe zone. In this between, we suggest to use carbon fiber system that are very helpful to reduce the artifact on the imaging and on the planning. The other point is mechanical, as a vertebral body collapse has been described in 40% of stereotactic radiotherapy compared with 5% risk after conventional radiation. And so the mechanical point has been addressed by this staging system, which was proposed by the O-spine group, the so-called SINS. There are 6 parameters and a single score for each parameters. And if we have a score less of 6, we can consider that it is stable. More than 13 is unstable. What does it mean? The simple concept is if a radiotherapist or somebody who is not a spine surgeon see one of these patients and the scoring is more than 6, should consider to take the opinion of a spine surgeon, as stability is not determinate. Under 6, radiotherapy is effective without any problem. Otherwise, there is a risk of fracture. So this system has been accepted in the scientific community. There are a lot of studies. It is included in the decision-making process, and sensitivity and specificity of SINS has been is near perfect, and it's very interesting. So let's go finally to describe it as myself and Alessandro Gasbarini. We worked together for many years now. I've left Alessandro working at Rizzoli Institute, and I was last to introduce briefly our flowchart, which include all the concepts that I have talked about now. Our idea is that we have several kind of treatment to offer to the patient, just palliative care or vertebroplasty, till big surgery or combination with radiation and medical oncology. And these are at the end of our flowchart, starting with the operability of the patient, which is the systemic point, considering the neurological symptoms, and then the oncological aspect, in dividing the cases where surgery is the only option, or radiotherapy or chemotherapy are an option. And then we have to consider the cases with mechanical problems where there is a risk of fracture or there is a pathologic fracture. Let me show case by case what is our idea. So this is one example. This is a multiple metastasis, multiple myeloma in a 75 years old in a very bad condition. There are visceral mets, ASA is 4, so the anesthetists say that we have no possibility. So ASA is 4, which is a systemic point, which is negative. And so we can consider if there are some sensitivity to chemotherapy or radiation, if there is no other option. So these are patients that should be addressed to palliative care, or maybe, as in this case, adding with the vertebroplasty. In this case, vertebroplasty is very helpful to solve, to reduce the amount of painkiller drugs, and so can be even performed without anesthesiology. And so these are the point where the patient cannot be treated. This is another case of myeloma with pain, instability, working impairment. And we can see that there is a Bilski-2, so it means that the tumor is invading the epidural space, compressing the cord, but leaving not displacing completely the cord. And so we have to create a room between the cord and the tumor in order to allow a better radiotherapy. If we consider the SIMS, the result is 11. It means that it is potentially unstable, but we must do the laminectomy, so it will become a fully unstable situation. And so if we see our flowchart, we see that this patient is in good general condition, and there is a spinal cord compression with possibility of recovery. The green line means yes, the red means no. There is no increase in damage. The patient is not an emergency of the Friday afternoon. And so we can consider not only the neurologic, but only the oncological aspect, but there is a mechanical point. So before referring the patient to the medical oncologist and to the radiation oncologist, we have to fix the spine. So good condition, neurological problem, oncological aspect consider mechanical point. So the result is that first of all, we perform a fixation, in this case with carbon fiber system, separation surgery. And you see here that we have separated the tumor from the neurological element. We have stabilized with this radiolucent implant without titanium, and then 44 grays and 1 year follow-up without any evidence of disease, without pain. And this is another case when there is a lytic lesion in the vertebral body. Biopsy arrived to the conclusion that it is a metastasis from lung adenocarcinoma. The SINS is 5. 5 means that it is stable. So we are surgeon, but it doesn't mean that we have to do surgery every time. So according to our system, it's in good condition. There is no neurological problem, the red line. From the oncological point of view, there is a red point, and there is a green line. It means yes. There is no pathological fracture, as SINS is 6. And so the patient should be addressed to medical oncology for the treatment. And you see the result after 1 year, after target therapy and radiotherapy without any surgery. So there is no risk of fracture, and the tumor, the histology of the tumor is highly positive for a target treatment. So it means that no surgery is necessary. This is a final case, the 35-year-old woman with a renal cell, single metastasis in L5, 3 years after the nephrectomy. So it's a typical situation where the patient is in good condition, so the systemic is good. There is no neurological problem, so it's a red line. And there is no possibility of medical oncology of radiation, as we had no access to stereotactic radiation at the time. It is isolated metastasis, is the green line. So you remind the concept that was reported before about oligometastatic, only one metastasis with a very good prognosis at even longer than 2 years. So in this condition, even very aggressive surgeon. Then she died for disseminated disease after 6 years, but she lived with a very good quality of life for all these 6 years, notwithstanding the very aggressive surgery. So just to say that in few cases, very aggressive surgery can be helpful. So this is my last slide. To remind that the decision-making process in the treatment of bone metastasis should be based on diagnosis, systemic assessment, neurology, and the assessment of instability. So we need histologic, histochemical studies. We must understand and study the patient. The neurological pattern should be very careful study, both clinically and radiographically, and then SINS is a very good system to assess the stability. So NUMS means neurological, oncology, systemic, and mechanical elements. And these are the 4 very important points to decide what to do. And it's very important that a surgeon with an oncological treatment is not important if you come from orthopedic or from neurosurgery. Very important, if you want to treat bone metastasis, you should have an oncological treatment to understand the different behavior of different tumors. Laboratory specialist, radiologist for diagnosis, pathologist for histology, interventional radiologist for vertebroplasty or for embolization, for example. And we have also to refer to medical oncologist, radiation oncologist, anesthesiologist, pain control specialist. So it is a huge group of people that should address to these tumors to achieve the best treatment, and finally also the rehabilitation specialist. So thank you very much for your attention. This is my group in Milano at the Istituto Galleazi, where I'm working with Pedro Bergiano and Claudia Lamartina, working on degenerative Max Sabi, and Paolo Lepori is a neurosurgeon, and I'm working on spinal tumor. So thank you very much, and I'm waiting for your question.
So thank you so much, Dr. Boriani. It was a superb presentation, I must say, of a very superb, nice presentation and nicely comprehensive overview about metastatic spinal lesions and how to approach them. I'm sure many of us would have some questions. Dr. Dalvi, Dr. Bapat.
Can I ask?
Yes, Dr. Srivastava.
Yeah, Dr. Boriani, excellent talk. We came to know so many things. You very rightly told that we have to have a balance between this very excessive and morbid surgery to have a balanced surgery, and moreover we should not even neglect the longevity of the patient, and we should give the maximum to this patient so that they can have a fruitful life. But in your center, how do you decide to have a very balanced? Just you follow that flow chart, or you use some scoring system which you adhere to?
No, well, we always follow our flow chart, as I consider that the scoring system are not very helpful for daily activity. So you are in front of a patient, I don't think that it is practical to perform a score, an addition of several scores and decide which is the treatment. It is better, in my mind, to collect all the data than to sit down with the different specialists and see if the patient is in good condition, how is the nutritional status, then which is the neurological problems, or if not, which is if there is a risk of fracture, and most important point, which are the weapons that we have outside surgeries. As today, most of different kind of histotype have different target treatment, which are very, very, very effective.
Thank you.
Dr. Boriani,
Yeah.
so when you are treating a metastatic tumor, how do you decide, is embolization, especially when you're doing an en bloc resection, embolization is like a must step you will do for every case, or you had to choose it as per your histopathological diagnosis?
Thank you for this question. This is very important. I think that embolization is very helpful anytime that you decide to perform intralesional excision. As in some of histology, the tumor is very bleeding, like renal cell carcinoma, for example, or some kind of breast carcinoma, and they are very bleeding. And if you decide to even perform a separation surgery, it means that you have to resect piecemeal the tumor. You risk to have a huge more blood loss, and so embolization is very helpful. We have seen that surgery becomes quite fast and more effective as you succeed to do it better. You can see better, the risk of complication is less, and the general condition of the patient at the end of surgery is much better, obviously, as the blood loss is less. And also from the immunological point of view, you know that the blood loss can compromise the immune response of the patient. So I think that embolization is really very helpful anytime that you decide to perform intralesional excision.
Manish?
I have a question. Thank you, sir. So how in a radiosensitive tumor, like say breast, sometimes thyroid, how often you have seen reconsolidation of the vertebral body after radiation, where you did not have to do an anterior reconstruction? Does the bone get reconsolidated after radiation in radiosensitive tumors?
Well, this is a very good question. As some very radiosensitive tumor, like myeloma, for example, they have a very good response but the risk of fracture remain, if the SINS is high, the risk of fracture remain quite significant. And the osteoblastic response is not always so strong. And so I think that if the SINS is less than 12, maybe radiotherapy can be the first option even without surgery. But if the SINS is more than 12, it is better first to perform fixation and then to refer to radiotherapist.
Yeah, in such a case,
there is an edge. You must decide otherwise you risk that the patient has a pathological factor during radiotherapy, for example, and this can be a bad situation for the patient with a neurological complication.
If there is a large lytic lesion but no collapse, if there is a large lytic lesion, say in a junctional region D11, D12, but no collapse,
yeah.
So would you go for an anterior, say a breast?
Breast.
Yeah.
If it is huge and there is a compression on the spinal cord, I think that it is mandatory to make a decompression and fixation before referring to the radiotherapist. Obviously, there are different options, but also you must also consider your local organization. As in the States, they have everything in the same hospital with the radiotherapist and the surgeon. But here in Italy, we are our hospital, and then the radiotherapist is in another hospital, and maybe there is a waiting list for radiotherapy. And so I think that surgery, decompression and fixation is helpful to prevent that the patient, while he's waiting for radiotherapy, as a fracture and resulting with neurological problem. Obviously, if my friends in the state hear this, they say, "Oh no, I can do this the same day." So okay, if you can do the same day is different, but we have not this. So you must. I think that our flowchart is useful as can be adapted to different environment and different organization.
Thank you.
Thank you.
Any more questions,
yeah,
guys?
Dr. Boriani, if I may ask you, sir, what is your experience with carbon implant systems? Do you think that they are strong enough to give you stability for the long time, especially in many of these tumors where we don't actually doing radiotherapy after the surgery?
I don't know if I understand. There was some echo. You're asking me if only posterior fixation is enough, or you are addressing about carbon fiber system?
So he's addressing about the carbon fiber system, sir.
Well,
is it strong enough?
Yeah, yes. The carbon fiber is even stronger than titanium from this point of view. As Lamborghini are done by carbon fiber, and the new Boeing aircraft are done by carbon fiber. So carbon fiber has an elastic response, which is much better than titanium. So the risk of breakage is less, and obviously they cannot survive if there is a complete loss of anterior column. So it's the basic biomechanical principle must be respected. So if we have a case where there is the vertebral body completely destroyed, and the tumor is not radiosensitive, so in this case it is mandatory to reconstruct the anterior column. Otherwise, even you do a double rod, 4 rods, titanium or carbon fiber will break. But carbon fiber is very helpful, as there are no artifacts, and so radiotherapy can be planned better, and you can even perform proton therapy and carbon ion therapy. These are the major advantage of carbon fiber systems.
Thank you.
So any more questions, guys? I think that was a great
Last
presentation and a
one.
great. Yes, Ayush, last one, please. Hello.
Hello.
Yes, who is this? Hello.
Is the number of surgeries that you're performing now is reducing because of better chemotherapy and other methods of management?
Yes. Yes, I think that step by step, we must follow the improvement of our colleague, medical oncologist and radiation therapist, and step by step surgery can become less aggressive. And I think that we will arrive to be able to avoid to do such aggressive surgery. And obviously we must keep this in our hands, but I think that we are going towards an evolution. And what is important in our flowchart, that this flowchart consider the different possibility of our colleagues and support the idea that multidisciplinary approach is mandatory. Obviously, if you live in a country like some part of Italy, where there are no radiotherapists, or there are small limited access to medical oncologists, so in this case, aggressive surgery remains the best option.
Dr. Boriani, do you feel there is a role of minimal invasive surgery in tumor, because suppose there is a impending instability and you don't want to really excise the tumor and your medical colleague is going to take care. So have you been using this mode of, fixation, the minimal invasive way of fixation?
Yeah, you're right. You're right. It's exactly what I tried to say before, that as soon as the other specialties improve, our surgery can be less aggressive. I support, however, the idea that minimal invasive surgery should not be a target. Minimal invasive surgery is a way to achieve the same result. So we should never perform minimal invasive just to perform minimal invasive. Minimal invasive is helpful if we achieve the same result achieved by other kind of surgery.
Thank you.
Thank you.
Okay. Any more questions, guys? So thank you so much, Dr. Boriani. Thank you so much for your time. Thank you so much for sharing your enthusiasm and your weekend evening with us. We are deeply enlightened and we are related to have you as always. Thank you so much, sirs. From all of us at the Bombay,
keep in touch.
Yes, sir, surely. Thank you so much from all of us at the Bombay Spine Society, sir. Thank you so much.
Thank you very much.
Thanks.
Thank you. Thank you, Prof. Boriani.
Thank you.
Thank you, sir.
I'm looking forward to visit finally Bombay. When it will be possible.
Yes, we hope so.
Welcome.
Soon.
Welcome.
We hope so soon, sir.
Yeah,
Thank
Dr.
you.
Boriani.
Thank you.
Bye.
Bye. Thank you, guys. Thank you, all of you. Sir, thank you so much.
Yeah.
Good night.
Good night.
Thank you. That's a
Thank
great
you all.
meeting.
Thank you.
Thank you all.
Thank you, Sandeep. Thank you.
Good night, everyone.
Thank you,
Thanks,
Neeraj.
Sandeep, Amit, and Uday for organizing this. It has been a wonderful session.
Enjoyed.
Thank you. I enjoyed it. Nice.
Chalo, guys. Bye. Good night.
Bye-bye.
Have a great weekend.
Bye.